Good afternoon, everybody. My name is Ahmed Shawky. I'm a professor of cardiology at Ain Shams University. It's a pleasure having you in this review course with the Egyptian Society of Cardiology. And today we're going to discuss the classification and pathophysiology of hypertension. What is the blood pressure? The blood pressure is the force exerted by the circulating blood on the arterial walls. It is one of the principal vital signs that we should take in every single patient, regardless his presentation. It is composed of two parts. The systolic blood pressure, it is when the contraction of the left ventricle forces the blood into the aorta and the blood vessels, and the diastolic pressure, which is mainly the pressure in the artery when the ventricles are relaxing, and this is considered part of the peripheral resistance. So the components are the heart rate and the stroke volume. The heart rate affects the cardiac output. The stroke volume affects the peripheral resistance. And these two entities constitute the blood pressure or the arterial blood pressure. We should know that the most important cause of mortality all over the world is cardiovascular disease. Nearly 18 million people die each year because of cardiovascular disease. And the most important risk factor for this is hypertension, regardless the age, regardless the socioeconomic standards. This is important to take into consideration that high blood pressure increases the mortality of up to 10 million people per year. Control of this blood pressure is important, and we should know that blood pressure is variable. It's according to the age. A young child does not have the normal blood pressure of an adult or an elderly. Second of all, controlling this blood pressure reduces mortality, very much seen in stroke and also seen in coronary artery disease and heart failure. And we're going to discuss the definitions and classification of hypertension according to 2017 American Heart Association ACC guidelines and the 2018 ESC or European Society guidelines for the management of arterial hypertension. Both are very concise and in definitions and in management of hypertension. So what is the definition and classification of hypertension? If you look at the American guidelines, there was a big row in 2017. Actually, they don't differ from the old definitions that a normal blood pressure is what's below 120, what's below 80. Of course, this is all in adults. Then there is this elevated blood pressure between 120 to 129 in systolic and still below 80 in diastolic. Stage 1 hypertension has changed. They changed stage 1 hypertension from 140 and above or 90 and above to 130 to 139 and 80 to 89 diastolic. This was a big row because a lot of patients between overnight, there was maybe 22, 23 million Americans that were considered pre-hypertensive, were considered stage 1 hypertension. And stage 2 hypertension in the American guidelines is anybody above 140 and above 90 diastolic, either or. So this is important. It was a big change done in November 2017. In June of 2018 and reiterated in August 2018, the European Society of Hypertension and European Society of Cardiology published their guidelines, but they did not change the definitions of hypertension. The optimal was below 120 over 80. A normal blood pressure, which was elevated blood pressure by the American guidelines, was 120 to 129 and 80 to 84. And grade 1 hypertension started at 140, not 130, at 140. And diastolic blood pressure in grade 1 between 90 and 99. Grade 2 hypertension was over 160 to 179 and diastolic between 100 and 109. But the severe hypertension or the grade 3 hypertension is what's above 180 and what's 110 or above. You might consider why there is a change in systolic 20 millimeters between each grade and 10 millimeters diastolic between each grade. Actually, it's because this what increases the morbidities and mortalities. An increase in 10 millimeters of diastolic equals the same risk as an increase of 20 millimeters in systolic. They also reiterated another thing. We see this sometimes in the elderly when there is isolated systolic hypertension, when the systolic blood pressure is above 140 and the diastolic is below 90 or fine. So these are the definitions of hypertension, the American and the European. Not only that, the Americans and Europeans insisted that a lot of patients who are not well diagnosed could undergo out-of-office monitoring. And this is very important, especially in patients when we are in doubt of their hypertensive status. And actually, the Europeans have a very nice box or table that shows the different definitions of hypertension according to the home blood pressure monitoring, which is 135 systolic and 85 diastolic or more. This is hypertension by the home blood pressure measurements. And in the ambulatory, the 24-hour ambulatory blood pressure, if it's above 130 and 80, this is hypertension. The daytime ambulatory, if it's 135 over 85, and the nighttime, if it's 120 over 70 or more. So these definitions of hypertension are quite important. And we know the out-of-office measurements are quite important in certain individuals. So the ambulatory 24 hours, or the home blood pressure monitoring in which the patient follows up his blood pressure or her blood pressure for 7 days. Now we're going to discuss what is an important part of hypertension, which is the pathophysiology, which is quite complex, and understanding the pathophysiology of hypertension will improve the way we manage our patients, because not all patients have the same presentation or the same pathophysiologies. First of all, we should understand the determinants of the blood pressure. It is an intricate system. It includes the sodium input in the blood, the number of functions of the kidneys and their nephrons, presence of stress and its definite change of the sympathetic nervous system, genetic changes, and sometimes we find families who are more prone to an increase in blood pressure than other families. Of course, a big epidemic seen all over the world right now, which is obesity, and also inflammation or malfunction of the endothelium. All of these will lead to a decreased infiltration surface, or an increase in the sodium retention, or an increase in the sympathetic overflow, with disturbance of the renin-angiotensin system, disturbance of the endothelial and its progenitor cells and its beneficial effects. This will lead to more and more peripheral resistance increase, which increases a lot the diastolic blood pressure. It will increase the contractility and the preload, which will increase the cardiac output. And as we know, a cardiac output and increased peripheral resistance cause an increase in the blood pressure. If there is autoregulation, sometimes there is countermeasures. But if the autoregulation fails, blood pressure will increase and hypertension will go. First of all, we should understand that hypertension can be classified as primary and secondary. Primary, which is the essential hypertension, which is usually said, because we don't know the cause, is more than 95% of cases. And we do not actually know exactly how it happens. We know a lot of pathophysiologies, but the correct mechanism or the exact mechanism is quite unknown. Secondary hypertension, it's much more simpler, because it is due to a secondary cause like endocrinal causes or renal parenchymal disease, but it is much less common. It's around 5%, maximally 10% in certain registries, but it's around 5%. In primary hypertension, there is no direct cause, but there are risk factors like a sedentary lifestyle, like obesity, and we see this much more in patients who are obese. Those with a high salt intake, and in our country, we are considered one of the highest salt intakers in the world. An increase in smoking or alcohol or a family history with stressful lives, all of this will increase the possibility of primary hypertension in our patients. Secondary hypertension, on the opposite, is rarer, and there are so many causes. You can see common causes like renal parenchymal disease, primary hyperaldosteronism, and this is one of the causes why sometimes spironolactone was initiated in patients with resistant hypertension, saying they might be primary aldosteronism. Obstructive sleep apnea, which is another problem because of the obesity, increased drugs, especially non-steroidals in the elderly, or alcoholism in those drinking a lot of alcohol. And there are uncommon causes like the Cushing syndrome, the pheochromocytoma, the hypo and hyperthyroidism, the aortic coarctation, which increases the blood pressure in the upper limbs more than the lower limbs, or others like congenital adrenal hyperplasia, etc., etc. But if you are going to look for a case of secondary hypertension, you might have a lot of investigations. But what do you suspect? This is the most important. Hypertension starting very early on as young patients. Hypertension that worsens very quickly. Resistant hypertension, and a lot of resistant hypertensions were seen to have primary aldosteronism as one of the causes. Severe onset of severe hypertension, presence of extensive of hypertension-mediated organ damage, or clinical features suggestive of the disease like obstructive sleep apnea, pheochromocytoma, hyperthyroidism. So you are presented with the disease itself. These are the lessons learned for secondary hypertension. Let's take a look at the pathophysiology of primary hypertension. Parts of this is the excretion of sodium, and an increased renal pressure increases the pressure inside the vasorecta, whether in the superficial or the deep nephrons. And there should be a decreased sodium reabsorption in the proximal tubules and the ascending lumen of Henle. And also there is the decreased sodium resorption of the deep nephrons. But if this does not work correctly, there is an increase of retention of sodium, and the sodium increases the blood volume, increases the blood pressure. Also, in patients who were having a low birth weight, sometimes the filtration surface area is reduced because they're impaired renal development. This also causes an excessive load of sodium because of the reduction of the filtration surface area. This leads to an increase in the blood volume. This increases also the blood pressure. But the biggest problem is our ingestion of sodium. And in our country, we ingest a lot of sodium. You might think sodium increases just the blood volume through its osmolarity. No, it changes a lot. It changes an increase in sympathetic overdrive. It increases the renin-angiotensin aldosterone system, and thus it increases also the peripheral resistance, not only the cardiac output and the increased volume. So the blood pressure by increased sodium ingestion entails not only the osmolarity and then increase in the blood pressure due to the volume. No, there is alteration in the sympathetic nervous system. There is alteration also in the renin-angiotensin aldosterone system. And the control of sodium by urbane is really distorted, and thus peripheral resistance, cardiac output, blood pressure increase. And this is an example of how this occurs through the renin-angiotensin system and the sympathetic nervous system. And some genetics, not only low birth weight, some genetics might increase the sodium and the sodium sensitivity of hypertension, thus decreasing the pressure natriuresis, increasing the tubular-glomerular feedback, decreasing the sodium chloride excretion. And this leads sodium-dependent hypertension. So sodium restriction is an essential part of hypertension, especially in our country, because again, I have to say this, we are ingestors of sodium. The renin-angiotensin system. And again, the renin-angiotensin aldosterone system is one of the most important targets in the management of hypertension. We know angiotensinogen is cleaved by renin to angiotensin, and then it goes to angiotensin II. Angiotensin II is quite deleterious. It increases the sympathetic activity, increasing heart rate, increasing contractility. It causes tubular sodium reabsorption, increasing potassium excretion, and this increases the blood pressure. It causes vasoconstriction, and this increases peripheral resistance and the blood pressure. And it also affects the antidiuretic hormone, leading to water absorption. These deleterious effects of angiotensin II are quite bad. And in certain patients, in a lot of patients, this is part of the problem. And this is why, again, a target for managing blood pressure are the RAAS system inhibitors, whether the ACE inhibitors, whether the angiotensin receptor blockers, whether the direct renin inhibitors. These might help this cascade, and this cascade is one of the most important that we should know. And the blood pressure increases in RAAS, again, is not just because of the peripheral resistance, it's also because of the cardiac output, regardless of the renin activity. Again, this deleterious effect is important. And here is a diagram showing you what is the sequelae that occur with this alteration of the renin-angiotensin aldosterone system and the treatment effects that can have an effect on this alteration. Again, usually when we have a high renin, the body usually goes with the low sodium and it auto-regulates the system, so keeping the blood pressure equal. But what if there is a failure of this renin-sodium relationship? There will be an increase in hypertension and there will be a high renin essential hypertension, and then we can have an increase in blood pressure. So again, the renin and sodium have a different relationship with each other. The sympathetic system, again, a very important target in managing hypertension, especially with the beta blockers. We know sympathetic overflow increases the heart rate, stimulates the renin-angiotensin system, increases vascular resistance, and this vascular resistance with the hypertrophy causes problems in the endothelium, even causes problems with the platelets, and can cause an infarction, whether in the heart or the brain. So the sympathetic nervous system not only increases the heart rate, it causes alterations in the vascular endothelium, and this causes an increase in blood pressure. The blood vessels, which constitute an important part to manage the peripheral resistance, also have several alterations that might occur, whether it's abnormal ionic fluxes, this through the sodium-potassium ATPase with an increase in cell calcium. This increases contractility in the heart and also increases the vascular hypertrophy and resistance overall. Also, the sodium-hydrogen exchanger activation that can be seen whether in the renal proximal tubules or the vascular smooth muscle cells will increase the vascular tone, increase the hypertrophy of the vessels, and vascular wall thickness will increase, peripheral resistance increases, hypertension increases. And this is quite important when you have a diastolic blood pressure. You need a good amount of vasodilators, and this is another important target of therapy. Also, with the inflammation, with the cell damage, one of the most important vasodilators and one of the most beneficial mediators of the smooth muscle cell, which is nitric oxide, which is a very potent vasodilator and very protective, is lost. Then you get extravascular hypertrophy, you get more and more increase in the peripheral resistance, and this increases the blood pressure. And this is a diagram showing how the intima, media, and adventitia of the blood vessels are affected by the several mechanisms we were discussing, whether it's the increased medial tone, the adventitial fibrosis, or the hyperplasia of the intima. Not to say also lipid deposition, ischemic heart disease, coronary artery disease, cerebral vascular disease entails, and this increases the morbidity and mortality from hypertension. And the oxidative stress that occurs through the activation of the different systems also leads to the endothelial dysfunction, with a reduction of nitric oxide, increase of reactive oxygen species, and this increases the contractility, decreases the nitric oxide, and increases the peripheral resistance, and thus the hypertension. One of the biggest problems, and we know in our country, we are one of the biggest countries having an epidemic of obesity. And obesity has a lot on hypertension and a lot on different diseases. Actually, there is a lot regarding the insulin resistance, and this hyperinsulinemia increases the sympathetic activity, causes sodium retention, causes vascular hypertrophy, and thus hypertension. And this effect of the insulin on the vasodilatation of the blood vessels is also affected. Instead of ample vasodilatation, we get impaired vasodilatation, there is a more depressor action, and this increases the blood pressure. This is the insulin resistance effect that we see a lot in those obese patients. Also, we discussed the genetics have a problem. Genetics can occur due to inflammation, due to obesity, due to dysfunction of the sympathetic nervous system, the renin-angiotensin system, and natriuretic hormones. This can increase the vasoconstriction, renal salt and water retention, which increases the blood volume, peripheral resistance, and blood pressure. This is why sometimes we find families in which the blood pressure increases at an earlier age than others. So we have to take in consideration there are a lot of risk factors. There are risk factors that we can change. There are risk factors we can't change. Nobody can change his age, gender, race, or family history. But we can change our weight. We can improve our physical fitness. We can reduce the smoking or stop it better and better, and alcoholism. We can have a better diet, control of our risk factors like diabetes and stress. So actually, understanding these factors will help us manage the patients through a better lifestyle modification. Finally, we can discuss the pathophysiology of the isolated systolic hypertension. In our elderly patients, a lot of the times we find that the systolic blood pressure is elevated with a low or normal diastolic blood pressure. This occurs due to the aging of the aorta and its rigidity. Sometimes other things can happen, like the increased cardiac output, like aortic valve regurgitation, if it's significant, aortic AV fistulas, thyrotoxic crisis, beriberi disease, and hyperkinetic circulations. These also increase the systolic without a major effect or even lowering of the diastolic blood pressure. So it's mainly in our elderly because of the rigidity of the aorta. In others, it's mainly due to the increased cardiac output. So to summarize, blood pressure is an important effect, and it's controlled by several mechanisms. The baroreceptor reflex located in the carotid sinuses in the aortic arch, the renin-angiotensin system, the arterial blood pressure adjustment by the kidneys, and the sodium, which is important. Endogenous vasoconstrictors like angiotensin 1 and reactive oxygen species. Aldosterone release, and this also affects the sodium content and also the vascular tree. So regulation of blood pressure is controlled by different mechanisms throughout the body. And hypertension goes if there is an inability of the kidneys to excrete sodium effectively, if there is an overactive renin-angiotensin system with increased vasoconstriction and retention of sodium and water, an increase in sympathetic nervous system, and these mechanisms are the main hallmark of how to manage increased arterial blood pressure. Controlling these mechanisms in addition to lifestyle modifications, as we've seen in our non-modifiable risk factors, can improve control of the blood pressure. So our take-home messages. First of all, this is the most important risk factor ever. Hypertension kills around 10 million people per year, and it is the most important or prevalent risk factors for atherosclerotic cardiovascular disease, which is the #1 cause of death worldwide. The definitions have changed. We've seen that the Americans start stage 1 at 130, while the Europeans keep the last recommendations at 140. So there is a little bit of change, but whatever definitions you take, we know that hypertension should be controlled quickly on, and not all patients who have a 130 to 140 should be given medications. It's according to the risks, and I'm sure this will be explained in other modules. It is primary or secondary, and primary is in 95% of cases. It is not due to a certain cause or a medical problem. It is not due to endocrinal problem, renovascular problem, or renal parenchymal problem. It is mainly due to the pathophysiologies we were discussing through the sympathetic nervous system, the renin-angiotensin system, the sodium, and the kidneys, how they regulate the sodium throughout. And this interaction between the different pathophysiologies has led the way of managing these patients, whether it's medications to reduce sodium, medications to reduce the renin-angiotensin mechanism, or beta blockers to decrease the sympathetic overflow. Secondary hypertension, which is less common, is due to a medical condition which causes a rise in the blood pressure. Not so common, around 5%, and we should look out for what patients, through their symptoms, signs, and treatment of the cause is always here the most important, not just treatment of the symptoms, which is hypertension. I hope we had an overview of the classification and pathophysiology of hypertension, and I wish you all the best. Thank you so much.